We are ready to start this Fujita Bantane Alumni Association webinar. Thank you for joining today. First of all, as always, I want to start with thanking Professor Yoko Kato, who is our mentor and who has been and still is our supervisor for many years. Thank you to my co-moderator, Professor Ishu Bishnoi. And our commentator today will be Dr. Bonsang Liu. Thank you, Bon, for joining us. I also want to introduce our discussants today, Dr. Sukirti and Dr. Biswas. Thank you for your help in this webinar, as always. Today we have two speakers, as usual, Professor Sarah Olson and Dr. Petra Wahjoepramono. I want to thank our speakers for accepting our invitation. They will present some very interesting talks about very intriguing topics. Before starting with the introduction of the first speaker, I would like to ask Professor Kato to give some introductory words to the audience. Thank you, Professor.
Thank you, Arbel. So thank you, everyone. Today's two talks, the title is so interesting, I think, for all of us. So that we are very much expecting the talks. Thanks so much.
Thank you, Professor Kato. So I agree, very interesting topics. One is about functional neurosurgery, and one is about training and recruiting young neurosurgeons among medical doctors. So very interesting topics for young neurosurgeons. The first speaker is Professor Sarah Olson, who is Associate Professor at Princess Alexandra Hospital, Brisbane. She has been the president of the Neurosurgery Society of Australia and New Zealand, and she is chair of the Surgical Education and Training Board for Australia and New Zealand. She has specific interests in functional neurosurgery, laser, interstitial therapy and facial pain, pituitary surgery, neuro-oncology and gamma knife. And today, Professor Olson will talk about laser interstitial thermal therapy for cancer. So thank you, Professor Olson, and you can start sharing your screen.
Thank you very much. You can see my screen okay?
Yes, we can. Thank you.
Lovely. Lovely. Thank you for inviting me. It's wonderful to see some old friends and also to meet some new ones. So I want to talk a little bit about us starting laser in Australia and some of the little pitfalls we've had and some of the real benefits I see with it. Sorry, it doesn't seem to want to move on at the moment. Sorry about this. Okay, so I first heard about the laser when I was learning how to do gamma knife thalamotomies in Marseille with Jean Regis. And Prof. Gross was there from Atlanta, and he was talking about it. It's about 10 years ago. And I thought, well, that's interesting because lasers have been around for a very long time. And I was aware of their use back in the 1980s. And I thought, what makes these different? So just monitoring things over the next 10 years, you could see that there was a real growth in the number of laser procedures that were going on and the number of hospitals acquiring lasers. So basically, we all know that thermal damage in target tissue is a time and temperature dependent effect. Once you get to about 60 degrees, you get instant denaturation of proteins and cellular components and tissue coagulation. So the real difference with these lasers is they had a lovely cooling mechanism around them, which enabled us to control the temperature much better than their prototypes. So the laser itself is about 12,000 US each fiber we use. So at least in our country, I can only use one per patient, which limits me to 2.5 centimeters in diameter of a lesion. It doesn't matter how long it is, it's just 2.5 centimeters in diameter. You can pull your laser fiber back along to get a long cylinder type structure, but I can't get wider than that unless I use another laser. Now, for cancer, I will need to use steroids for a little at a higher dose for about 2 weeks, and then the edema will resolve over 2 to 9 weeks. You get this very sharp transition zone between dead and viable tissue. So the indications have been in metastases and radionecrosis. Because I work in gamma knife, it works very well hand in hand with working in a gamma knife unit. Glioma, I haven't done any as yet. Epilepsy and pediatrics, which I'll talk a little bit about. In pediatrics, for hypothalamic hemorrhage, also in young patients where you might want to avoid using radiation for some period, if you can use laser, that can enable some time for the brain to develop. So for glioma, deep-seated or difficult to access lesions, lesions resistant to all other therapy, patients who can't tolerate an open resection, and interestingly, a comparison of patients undergoing biopsy and chemoradiation showed a comparative survival to those having biopsy and lit. So in some cases with these deep, small lesions, people are doing the biopsy and lit initially and waiting to do the biopsy and chemoradiation down the track. Recurrent GBM, those treated with lit had a survival a little better than those treated with lomustine and Avastin. And there was less morbidity in the lit group than with the chemotherapy group. Epilepsy is appealing for a minimally invasive option for intractable patients. Amygdala hippocampectomy, that's a long, thin structure. The seizure freedom is not as good as with an open resection, but the neuropsychological outcome seems to be much better with the laser procedure. So as you can see, long, thin structure, no more than 2.5 centimeters. So while you're in the MRI, you start at the depth of the lesion and you pull the laser back. So you might do that 5 times to get an amygdala hippocampectomy lesion. Similarly, corpus callosotomy, that's a long, thin structure. It's very well suited to laser. Metastases is where I'm most involved with my work in gamma knife. We know that 20% or 1 in 5 of them seem to be radioresistant or they're treatment failures. And laser is a similar cytoreductive effect comparatively to resection. Radionecrosis, I think, is really where it's quite wonderful. It occurs in up to 25% of patients. And whilst this data said 100% lesion control, I never quite believe 100%, and I have had one failure, which I'll talk about. And you can get patients off steroids much more quickly with laser as opposed to the medically managed patients. So there's been a position statement on laser for brain tumors and radionecrosis. It has a very short recovery time. Patients really can go in and out the same day, although we keep them overnight. Low rates of rehospitalization, quick wound healing, and they can have their adjuvant treatment sooner, and there's no interruption to the treatments they're on currently. There's a consensus that intracranial lit should be considered in patients with recurrent or progressive malignant tumor inaccessible to surgical resection, or where the patient cannot tolerate surgery. And I'll talk a bit about that in patients that have had radiation, have a lot of swelling, who are steroid dependent. We all know they're pretty frail. So I've really tended to use laser in those patients rather than open surgery. So laser is a treatment option for relapsed brain metastasis and radiation necrosis. It's typically just the one stitch closure. This is the first patient I did. I purposely chose a patient that I could either take it out or I could try laser. So we were using a stealth system. We did an O-arm spin. I got a CT and MRI the day before. And we used the Medtronic robot for the biopsy. So at this point, I was doing the biopsy at the same time I was doing LIT. I've subsequently found out that when you're doing a biopsy, you do create a tiny hemorrhage in the lesion, and this alters the heating characteristics in the lesion for when you're trying to ablate it. So I'm now tending, at least in the last couple, to do the biopsy a week before and then come to do the laser afterwards. I've had a mix. The robot's been largely good, but I think if I'm going to do a deep lesion, I'm going to use the frame, which I'll talk about a case why I found that the robot a bit of an issue. So this little screw here, a lot depends on that little screw. You've got to get that in exactly the right trajectory. And the first time I did it, when you drill the tiny burr hole for this to go into, it wasn't quite deep enough, so I re-drilled it, and then the screw wouldn't thread. So that was an issue, which subsequently I've tended just to slightly overshoot the depth of the skull, just to make sure I don't run into that problem again. And that has to be screwed down quite tightly, so that we can't have any movement in that, or you're going to be off. It's not moving again. Sorry about this. Ah. Anna? Sorry, 1 minute.
Yeah, sure.
I've just got to move this along. I can't seem to move that on here. It doesn't want to move to the, oh, now it's working. Sorry. So now we're measuring the laser fiber out. No problem. Can't move this along. Why is that not moving? This one needs to click up there. Just click on that left one. Okay, thank you. So the cooling catheter is what you're seeing here, with the saline comes in and comes out, and that's what makes these lasers much better than their prototypes. Because we don't have an intraoperative MRI, then the laser has to be kept very safe so it doesn't pull out while we're moving the patient to MRI. This is us coming down into MRI, doing the planning in MRI, looking at the coverage. So as I said, this is temperature and time dependent. We're getting a good coverage here. So I'll put in 3 temperature points that I want to get up to heat. If they go above the heat, then the laser will cut out. Similarly, I'll put in areas that I don't want to heat up, and if it gets to a certain level, it will then also cut out. So in radiation necrosis, the patients really could get off their steroids very quickly, and I found it to be really great for radiation necrosis. And it will also reduce their seizures and no neurological complications, very low hospital time. those who have experienced very little or no interruption to systemic therapy regimes, including immunotherapy, and even in the setting of subtotal ablation of the cancer, 76% of patients never experienced disease progression prior to death. And there's a thought, which I'll come to again, is that you can probably use more aggressive use of radiotherapy initially. Because we know with radionecrosis, there are other treatments. The steroids, we've all seen people horribly steroid dependent. Avastin, great in some people, but after about 6 months tends not to work so well. And then there are these other treatments for radionecrosis, which seem to work about 50 or 60% of the time. So this is a comparison of LIT and Avastin. So with LIT, the lesion will grow before it comes down in size. With Avastin, it will shrink, but it will stop working, or around the 6-month mark with Avastin, the lesion will get larger again. As is with LIT, it will continue to get smaller. So consolidation radiation, I think, has been really exciting in the last couple of years. So this was just a small study, but I've had a couple of patients that it's gone really well in. So if we use the laser and then we do consolidation radiation, to a level previously we would have seen as radiotoxic. The laser deals so well with the radionecrosis, we can really get a lot more into the lesion. And with this, these patients had excellent local control with consolidation radiation, and none of them developed radionecrosis. So if we give laser and consolidation radiation for recurrent tumor, the results were better than using radiation alone or LIT alone. So here are some cases that I've done. So this is the first case. As I said, I could have taken this one out. I took this one out and used laser for this one. This man couldn't tolerate his headaches on steroids, and his wife couldn't tolerate him on steroids. So I'm very pleased to say that he's completely off steroids now, 2.5 years later. This lady, now you can say, why didn't I just take this out? Well, I could have, but I find these patients are quite frail. They're steroid dependent, they're hemiparetic, the brain is very swollen, and they've had a lot of radiation, which is making it quite scarred in there and difficult to get out. And I found in the past, operating on radionecrosis in these type of patients, if you give them a hemiparesis, they really do very, very poorly, whereas the laser seems to work very well. Now, she was on a 4th-generation ALK inhibitor and had progression of the lesion. I treated her in 2023. At this point, she was hemiparetic. She was really struggling on a lot of steroids. I did not get complete coverage of this lesion, but she remains at 1.5 years later. This is what it looks like. Off steroids, back playing golf, and really doing very well. So this is one that didn't go so well, and I don't know why. He's a low-grade glioma, treated with chemo and radiation in 2022. He had this radionecrosis confirmed on biopsy, but it's just not improved at all, and I don't really understand the mechanism of why that is. He's the only one I've had who hasn't responded. This is a young man who had 38 melanoma metastases treated in 2019, all of which have been under control except for this one. And so I did laser treatment with concurrent biopsy. And once again, when I did the biopsy, the laser didn't heat up so well in the lesion where I'd taken the biopsy from. So I think this is a good thought about doing the biopsy like a week or so beforehand. And so that's it. It all went very well. This is him in surgery, and I didn't have to move it. It was just straight in one treatment. And this is him the day after. He actually flew to New Zealand to see his girlfriend the day after that. But unfortunately, he gets a recurrence with a hemorrhage. And we gave him further radiation to the point which previously would have been seen as toxic, as it had the laser, which we felt would deal with the radionecrosis, and then I took that out, and he's still free of disease. Now he's looking good. This lady had triple negative breast cancer, and we gave her our standard of care for metastases now is to do preoperative irradiation followed by resection to reduce the leptomeningeal disease and the radionecrosis. And I did that for her, and we did a motor evert potential mapping and resected that lesion. It's a tiny bit still, I felt, on a post-operative scan. 2024, I was asked to see her again because this is what was going on. So I went to see her, but unfortunately I found her like this. And we've all seen these types of patients. She's got respiratory failure from the steroids. And she's really in a bad way from these steroids. I certainly didn't want to give her a hemiparesis. So we opted to do the laser. It took a lot of work between myself, ICU, the respiratory doctors, radiation or palliative care doctor to get her ready to actually get to surgery. And she did really well. And I was delighted to see her back like this. This was a recurrent tumor. And before I knew, she was treated before I knew about giving the consolidation radiation. I learned about that at a ISRS meeting a year and a bit ago. And so when she recurred like this, I had just been to the meeting. And so I went to see a radiation oncologist and asked them whether they would do consolidation radiation for her, given she'd had the laser. We've subsequently done several others since. And they took a little bit of persuading, but we did it. And they noticed that her tremor response was excellent straight away. And she was quite quickly reduced again to off her dexamethasone, and now she is completely off it, and she's still doing really well. Another one, the same sort of scenario, that we do this to these people. It's truly terrible, I feel. And then they're so frail to be undergoing undergoing surgery, and they do so very well with a laser. So here we are over 3 months. Now, as I'm starting to do the laser as a second stage to try and help that heating problem that occurs if you do the laser in the same stage. So this is a guy with radionecrosis. Once again, you could argue about taking it out, but I don't get a lot of joy out of taking radionecrosis out surgically, especially when a brain is as swollen as this. He has also intractable seizures, and his one goal is to actually get him to be able to drive his son to school. So we discussed doing laser with him. I did the biopsy a week before, and then brought him back, and you can see it's not quite as well defined. And the other problem I had this day well, there were two other problems actually. Because I'd done the biopsy beforehand, of course, it was exactly where I wanted to put the laser catheter. And that burr hole for the laser is so much tinier than the one you do for a biopsy. So it necessitated another trajectory. The other problem I had was that the stealth was saying that I had a 0.6 millimeter error, which we appeared to do, but the robot was out. It took me parallel about 5 millimeters to the trajectory, and we are just behind it. So I felt the problem was actually with the robot rather than anything else. That's why I think if I get a deep lesion, I'll be looking at using the frame. Now, when I looked at all the cylinders and predictive modeling, it looked as though we'd still get good coverage of this, so I proceeded. And interestingly, the tumor actually acted as a heat sink, and the heat went to it rather than directly around the catheter. So he's had a good response. This is another patient I'm planning to do with epilepsy with a DNET. So yeah, it's a nice deep lesion, small lesion, ideal for a single catheter. So I think, there aren't heaps of cases, but for those people that have it, they don't have a lot else, I feel. And so I think it's an important new therapy. And even more exciting, I think, is we can be less concerned with radionecrosis. Certainly, I've certainly got a handful of patients that would not be alive if we hadn't done the laser, then done follow-up radiation to a point previously we would have been too frightened to do. That consolidation consolidation radiation is an exciting option. We don't have intraoperative MRI. I've had quite a battle with health funds to fund laser because those catheters are $12,000 US each. The outlay initially was just $1 million for the machine, but it's the catheter and the disposables that is the big issue. Thank you very much. Sorry about the problems there, the technology.
Thank you very much, Professor Olson, for this very exciting talk about laser interstitial therapy. I think we can open the discussion, and I would like to ask our commentator, Dr. Liu Bonseng, to give his comments or questions. Liu?
Yeah, thanks, Professor Olson, for a nice talk. It's the introductory, I think, technique for most of us. Although there are some centers they're using it for experimental purposes, but still not widely used. I would like to ask regarding stage treatment in LITT. There are reports talking about thermal tolerance, where you may need a higher temperature now for repeat treatment. Could you comment on this? Probably I give two questions. One is regarding local immune response due to thermal therapy. It may be beneficial for tumor cell. How about the adverse event for the normal tissue due to a local immune response with the thermal therapy? Professor?
Sorry, I just froze a little bit during that. So sorry, the first question was about
repeat, because you mentioned about the stage treatment. There are reports saying that repeat treatment may create thermal tolerance, where you need to now upgrade the temperature to get the response. So could you comment on that?
You mean with doing a biopsy first and then doing the laser, or repeat laser treatment?
I think the repeat LITT. Do you perform that, especially like, for example, like metastasis? Sometimes you may need to repeat the treatment. Yes. Have you ever faced this so-called thermal tolerance in those cases?
Look, I think there's a lot that's unknown about this, and a lot we need to figure out. I haven't done a repeat case. My young man, he's only 23 with all the melanoma mets, he may be one I need to do it again. And yes, there has been some data on that. But then we still don't know why some people are responding really well and others aren't. I mean, why did my radionecrosis guy, one of them, not respond? I don't understand that. This is a process, I think, that is still quite new, and we're all just trying to work out who will respond and who won't, and when best to use it. It's just what I've found so far, which cases seem to be doing the best, and it really is those radionecrosis cases. Or recurrent failures with gamma knife, doing the laser and then doing further consolidation radiation. We seem to be getting really good results there. So that's what we've noticed so far, but a lot of the other things are unknown at this point.
Yeah, I mean, do you have idea regarding? I seems like very important effect on radionecrosis. But however, the principle of applying temperature is to disrupt the protein in the cell, where radionecrosis are the dead cell. So how do you think that it works for radiation necrosis?
Yeah, that's a really good question. Obviously, necrosis causing necrosis. Yes, I think we've all struggled with that, or necrosis treating necrosis. I think it's just done in a slightly different way. It's like doing, the thalamotomies with gamma knife versus radio frequency versus focused ultrasound, or you can actually do them with laser. The necrosis seems to be caused in a slightly different way. Yes, I mean, the first time I was stunned by it, that it would work so well in radionecrosis when you're causing more necrosis. But yes, it really does. It really does.
Maybe my last question. Now we are trying to compare between no choice, but we need to compare between LITT and high field high focus ultrasound, which using the thermal therapy also both. One is invasive and one is non-invasive. In your opinion, what make the difference? Is it the precision, the predictability, which one should we promote as neurosurgeon, LITT or high field, focused ultrasound thermal therapy? Thank you, Professor.
I think that we've got so much work to do in this space to understand it all. I'm sure they've all got areas that they'll be, really good in. That's our job to work it out. Where are we best suited to use the tool we have, and when are we best suited to use another tool? I think we're still a lot in its infancy with these treatments, which is exciting.
Yeah. Thank you. Hope to hear more from in the future. Maybe you may venture into the high field ultrasound combined with SRS probably. So I think I opened the session for the other discussion. Alberto, thank you, Professor.
Thank you, Boon, for your questions. Is there any question from the audience? I have a question, Professor Olson. So can you point out not only the indications but also the contraindications of this kind of therapy, and how much do factors like age or general conditions impact on your decision to use this kind of therapy instead of something else, gamma knife or surgical removal or so on?
Yeah, well, I think as I said, the width of it is a problem. So 2.5 centimeters width. It doesn't matter how long it is, but you can't get your laser really to go more than 2.5 centimeters wide. So the size of the lesion is important. Patients who aren't well enough to undergo surgery, or I think I've mentioned, those group that we do it to them, it's all from treatment. They're terribly Cushingoid. They're very frail. The last thing you want to do is give them a hemiparesis from resection. I found the laser to be very good. So a lot of my ones have been in the motor strip or close by. Usually it's patients who aren't suitable for surgery. Gamma knife is usually being used already. And that's why we're either mopping up the ones that haven't responded to gamma knife or who have radionecrosis. So it works very well hand in hand with gamma knife, and it's enabled us to get a number of people through who otherwise would have died, I think, from either disease progression or from the radionecrosis. And so width is the problem, really. It has to be less than 2.5 centimeters wide. That's in the cancer realm. In the kids realm, I think, we talked about the hypothalamic hematomas, or again, 2.5 centimeters wide, unless you're going to use multiple catheters. But also in kids where you're really trying to delay the use of radiotherapy. So I think that's really important. Epilepsy, and my colleague's doing a lot of these in Sydney, and I'm saying to Mark, I think if I had temporal lobe epilepsy, I'd go for laser. Even though the efficacy isn't quite as good as open, the neuropsychological outcome is so much better. I think that and also anything that's long and thin, corpus callosotomy, small lesion causing seizures. One of my patients, his main problem from his radionecrosis is his seizures and his inability to drive. So my goal with him is to see, I want to get him back to driving. So hopefully in come 6 months, we can sort of say, we can look at that. And I'd see that as, that was my win with him. Those are the main indications: kids, epilepsy, deep gliomas, small, who have relapsed, metastases, and radionecrosis.
Thank you. Dr. Kumar?
Hello, ma'am. Thank you for such a nice presentation on laser interstitial therapy. I am Dr. Abhishek Kumar. Currently, I'm a fellow in Bandhani Hospital under the esteemed mentorship of Professor Kato. I have a question for you regarding high-grade gliomas. So in high-grade gliomas, as you said, if it is a very deep lesion or the patient's KPS score is very poor and patient is debilitated or is not in the condition to undergo primary surgery, so this therapy, lead therapy you are doing, I have a question that when you are doing, what in your experience, do you feel that there is an improvement in the post-therapy KPS score, or is there any survival benefit to these patients after you are doing this lead therapy? Second, my question is there any scope of combining immunotherapy or any blood-brain barrier disruptors with lead therapy in future?
Yeah, I don't know about the second question. The first question, I haven't done any gliomas. My colleague has in the recurrent setting in a young person. But, you know, it is like giving gamma knife to recurrent gliomas because it's, you know, it's got a sharp drop off. It's not really suitable to diffuse lesions. But, you know, I think, you know, where you're just trying to buy a little time, then it's reasonable. Deep, small, or whether your patient's not up to surgery. But as I said, that 2.5 centimeters limits you in its width. I haven't done any gliomas, but I am aware of a few going that way. And to use it with immunotherapy, unsure as yet. Obviously, that's looking at with we don't interrupt any of their treatment while they're having this treatment, which I think is fabulous because, you know, with surgery it can get interrupted for weeks. So these guys continue their therapy throughout, which is probably also a lot of the efficacy we see from it is it is never interrupted. But using it as a way of getting treatment in, I think, you know, well, most of the work with that is happening with ultrasound. Yeah, I've not seen it so much with the laser.
Ma'am, actually my question arises because I did one study on high-grade gliomas, and I found out that if the patient preoperative KPS score is low, so it is a very significant factor which will decide the post-operative KPS. The outcome highly significant. I found out the factor based on the histology, the KI index, the histology, the tumor grade, and the preoperative KPS score found out to be very significant, even more significant than the extent of resection. So I really wanted to know in your experience whether this therapy is means in general I'm asking provides any benefit to the survival of the patient. I mean, it's a very new thing for me, so I'm asking you.
Yeah.
Thank you for
Well,
thank you for your.
You could also
Yes.
see that, you know, some people are doing it for deep lesions with the biopsy initially and holding off on the chemoradiation because the outcome from just doing the laser with the biopsy was similar to doing just with the biopsy and the chemoradiation. So I think it's definitely offering another prospect. And we see that, you know, the effect of the radiation down the track, I think all of us would like to delay that as long as possible. And if laser offers an opportunity for that, I think there are some people going down that route of using it up front for the deep lesions with a biopsy and reserving the radiation and chemo for later on.
Thank you so much, ma'am, for guiding me.
Thank you. Thank you for your comment. Thank you.
Thank you. We have a question from the chat. How many lesions can be treated in the same patient? Is there a limit to that?
Only limited by the cost of the catheters. So most places will only allow you one catheter. So you probably saw a picture of my friend Ido from Tel Aviv who came out to help me with our cases. And he told me in Israel too, they're only allowed to use one catheter per patient. So unless you can get your lesions all in the same line, you can't easily treat multiple lesions. Yeah.
Thank you. Okay, we have also a comment about the fact that also deep-seated lesions can be removed surgically without deficits. Yes, I think so, but probably as we were talking about before, we need to tailor the treatment based on the condition of the patient, I guess. I see Dr. Kumar, or no, Dr. Bhakti. Who asked this question already. Okay. Is there any other question from the audience?
No, I think like you're talking about the deep ones, you know, initially when the patient's in physically quite well, we can look at taking them out. But by the time they've had radiation, chemo, they've been on steroids a long time, they really are pretty frail to be entertaining.
Thank you. So if there are no other questions from the audience, I don't know if Dr. Olson froze. Are you there, Dr. Olson?
Connection is loose, I think.
Yeah, I think she has connection problems. I cannot see her anymore. But I think we concluded the discussion basically already, because I don't see any other raised hand or questions. So probably issue we can move on to the next talk. So please, you can go ahead introducing the next speaker.
Thank you, Alberto. I would like to introduce our next speaker, Dr. Petra, who will be talking on trends in neurosurgery, recruiting young talents. And he is currently working in Indonesia, and he's doctorate in medicine from West Java, Indonesia, and currently working in Siloam Neurosciences Hospital. And he has special interest in endoscopic spine surgery. And today we'll be talking on for young students, medical students, for about the neurosurgery experience and what is the neurosurgery. So it will be an interesting topic for those young neurosurgeons who want to join in neurosurgery. So I would like to ask Dr. Petra to present.
Thank you, Vishnu, for the introduction. Hello, Alberto, Kato Sensei. Very good to see you today. I would like to share my screen. Okay. So, friends, this is a topic that is very dear to me, because right now in my medical faculty, we are actually opening the new program study for neurosurgeons. Usually it was just for medical students becoming doctors, but now for doctors to become neurosurgeons, we only opened this year. And so this topic has been on and off in our faculty for 2 or 3 years. Who do we recruit? How do we recruit? And then the new idea popped up. How about we stop worrying about who we will recruit, and we create people that we want to be neurosurgeons in the future. And so I would like to present to you what we did in the past 2 or 3 years in an attempt to produce better graduates. So this is recruiting young talents, neurosurgery for medical students. So as Ishnu has already said, I teach surgery at the university here in Tangerang in Indonesia. But now I will be moving to the neurosurgical unit to become a teacher there also. So, of course, why do we need new neurosurgeons anyway? We meet neurosurgeons every day, every seminar, but actually, as in the 2016 study shows, actually our area in the Southeast Asia region have a very low number of neurosurgeons per population. As we see in the right-hand picture, we're still in the red. Well, okay, a bit orange, but we're still in the red. Although the essential case consults per neurosurgeon is really quite high. So this means that there is a big gap that we need to fill in the neurosurgical workforce. For my country in particular, the ideal number will be 2,700 per 100,000 population, but now we're only up to 500. We have 8 programs nationwide, excluding ours because ours haven't started yet. So that means there's 60 new neurosurgeons every year. So provided that nobody new is born and no neurosurgeon retires, we'll need 37 years to have enough ideal number of neurosurgeons per population. Although this number has been contested lately, it has been shown that we need up to 150% more neurosurgeons per number of population to deliver good results. So also, not only the number of neurosurgeons, but also the type of neurosurgeons is becoming important, because in the old days, neurosurgeon, you need to do a craniotomy, you need to do a craniectomy, and you can do a VP shunt. All 3, and you're set for life. So if like a Swiss knife, you maybe only have a couple instruments in there, craniotomy, and VP shunt. But nowadays, with all the subspecialties, for example, Dr. Olson's laser tools as well, the Swiss knife doesn't become so simple. You need to do a lot of things: gamma knife, laser knife, radiation, transphenoid, endoscopic MVD, endoscopic spine. It's too much for anybody. So instead of training one person who can do everything, I think it's better that we have a number of people who are really the best in what they do. So the trend is we want more neurosurgeons because we want them to subspecialize, not only to just become the king in their own small area, but to subspecialize and to collaborate with each other. And so we need a lot more neurosurgeons today. Now, we know that neurosurgery is standing on the shoulder of giants. That means we have a lot of experience. We have a lot of experienced teachers, and using the knowledge they have already made, we become better. We can, well, not better, we can expand on what they have taught us. So how do we climb the giant shoulder? Meaning, how do we interest medical students to become neurosurgeons in the first place? Because that's what's important. So we already have help, because nowadays neurosurgeon is in a lot of mainstream media. So Marvel, Doctor Strange is a neurosurgeon. A lot of medical dramas are centered around neurosurgeons. So neurosurgery is cool. They have a lot of skills, they have a lot of smarts, and they have a good lifestyle. But the reality is really often very far from the dream, because where I come from, it's kind of a army city. So as you can see, well, it's Indonesian, but it says the training cannot be weak. Training has to be hard, whatever the reason. So that is what we are brought up to do. And this is my cadre when I was a neurosurgeon, 30 people training at the same time. And we are trained to be very individualistic. We are trained to be perfectionist. And nowadays, that is not an idea that is appealing to the young generation. Right now, they want something, good working hours. They want some field that they can master easily. They want something that has good returns. And so we have to bridge this gap between the reality and the expectation to make sure the medical students want to study. So what do? We have to improve ourselves. We find a way to teach neurosurgery that doesn't scare them, because in the old days, we point to a gyrus and say, what gyrus is that? And no medical student will want to continue to become a neurosurgeon if we just give them questions that they cannot answer. But also, we can't make it too glamorous, because many people are attracted to become neurosurgeons. Oh, they make a lot of money. They have a very good discipline, things like that. If we make it too glamorous and the training is too hard, then they don't want to continue. So we just have to give them the truth. So also, not only just giving them the truth of what the day-to-day life of a neurosurgeon is, we have to attract the right kind of students. So the right kind, in my opinion, will be kids who are curious, who are ambitious, and most of all, they are capable, not only just the smarts, but also the mental fortitude that allows them to be a neurosurgeon. And these kids, we give them a study plan, we give them an outlook on how to be a neurosurgeon so that they are interested. So the qualities of a good neuroeducator, of course, I would like to highlight here Professor Rokuya Tanikawa, because he just came to our country last month, and we had a very good experience over a 4-day workshop. Not only neurosurgeons, but also medical students came, and they are attracted because he is a master of his subject, but he can also communicate the ideas clearly. He made theories and he communicated them clearly, and he's very approachable. And he also, very importantly, made an innovation in the field of bypass. So his new bypass technique is now attracting not only neurosurgeons, but also medical students in how to perform such a complex procedure in a short amount of time. All this combined made the neurosurgeon become a professional and a role model for students to look up to. Now, so we need to provide a long-term interest in the students. So we ourselves, we have to practice how to convey complex neurosurgical topics in ways that they can understand. We can't just always expect them to study and raise up to our level. We have to be able to explain it clearly. So this would be halfway between explaining it to a patient or their family. This will be more technical, but still interesting in the same time. And this will interest young students and make them want to continue while showing them a glimpse into what we do in our day-to-day. So what we do in our center. So our team, as you can see in our coat of arms, we do brain and spine, but also we picked, instead of just operating, we have books, we have learning, we want to teach about these kids. So this is the philosophy of our design. What we do unofficially, of course, because this is before the neurosurgical residency starts, unofficially, we give internships for neurosurgery, we give students interest clubs, we give workshops for medical students and fresh graduate, and we have to touch up our social media game because this is where all the new medical students are interested in. Okay. So one of them is we want to involve them in internship, short-term and long-term. Short-term meaning a couple months. These kids, they have maybe 2 or 3 months before they have to go to their district hospitals. So we allow them to come experience the lifestyle. Not only do we allow them to sit in surgeries, but we also give them questions to take home. We give the microscope images to study, but also we give them achievements. For example, the video we made just now features a lot of medical student ideas, and some of them also play a role in it. This video is used for education. So for example, we want to give a talk about how to perform a good neurological examination. We'll give them this video. And also for some students, we also ask them to write papers for us. Of course, they will be the first author, and it doesn't have to be an international journal. Just as long as they have achievements, they will feel that, oh, okay, so we can do a lot of things in neurosurgery, and it will be a satisfying experience. So having internships, having students follow us is actually a very good thing for us and for them. Now, other than that, more importantly than just 1 or 2 students following us, we can give them an inspiration to have student-led clubs. So for example, this is our club we have. So this is focused for preclinical students. So they haven't entered the clinical rotations yet. So they have the time to study. We give them some room space. We put our educational models there. We have some aneurysm models, some brain and spine models, a lot of books and illustrations. And having student-led clubs is very important because we just don't have the time to think up new things for them to do all the time. So as a student-led club, they will come up with their own activities and they will recruit the next generation. And every time they do this, it will be modern. It will be more in tune with what the students need. And their activities can also help us, the neurosurgeon, on educational activities. We'll see later, but actually making videos like this, making patient education media is very important for our day-to-day life. Also, they become a very good place to recruit. For example, we give a talk to the club on how to be neurologists, how to be neurosurgeons, and hopefully in, well, I'll tell you in 2 or 3 years if some of them actually become neurosurgeons. And also, we need to provide workshops, not the really serious kind of workshops like what we do. We go to another country for a couple of days for training. This is too deep for medical students. So what we actually need to do is we actually need to give workshops not only for medical students, but they will also fit in with the general population. So we have general interest workshops, for example, basic life support, or medicine, or trauma management, not only about neurosurgery. Our upcoming project in October will be to have the advanced emergency management skills. So not only is it for trauma cases, to do stitching, to do patient transport and neurological examinations, but this kind will be more attractive to medical students for them to attend, and also for them to become part of the committee and make the event. And lastly, it's very important to have social media nowadays, because actually it's the best way to integrate into young people's minds and activities. A trend we're seeing now is that the students are spending less and less time on campus and more time in, coffee shops, because they have a lot of online things. We have to integrate into their phones. So I actually created some of the social media, not only to educate patients, but also to help inspire medical students, because anyway, they can't come with us all the time. We can only have 1 or 2 people shadowing us for internships. To have more people interested in being a neurosurgeon, we have to do this kind of things. And the benefits is also for our practice. Not only do we educate the patients with this, for example, this is an education about deep brain stimulation, but at the same time, we interest them in the neurosciences. And also, while making these kind of content, we have to study, because we have to stay updated. It's so easy for somebody to Google up what we say just now and say, oh, but there's a newer technique for that. There's a newer paper for that. This way, we have to stay updated every single day of our life. And I tell you, it's a pretty good experience for us. So now for our social media, we have about 400 posts, and we do this for patients, but also the ideas will come from medical students. Oh, what do we talk about next? And what is a up and coming event that is linked to neurosurgery, and we can provide the professional contents. Okay, so lastly, I want to say that in our experience, COVID was a big reset button, because medical students are now used to online learning, and the clinical rotations are also being, well, less interesting for students because they can't really come to the hospital a lot. I know COVID was 4 years ago, but we are feeling the effects just now because students don't know what they want to do. The continuity from their seniors is lost. They don't know what's interesting anymore. They really want to figure out how to live their life. So we have to show that our way, neurosurgery, is the best way for young students, because it's up to us to build the next generation. Who do you want to operate on you in the future? The students I'm teaching now will be neurosurgeons when I'm old. I don't know, maybe I'll have an aneurysm or something, or maybe I'll have a tumor, and these guys will operate on me. Because in the future, I want them all to be very, very great neurosurgeons, and they have a full set of skills. Each of them specialized to do their own branch of neurosurgery, vascular or oncology, what have you, and they will be the ones who operate on me in the future. Okay, so in conclusion, let's help them climb that giant. So instead of doing it the hard way, we can give them some interest. We'll build a bridge out of vertebra for them to climb up to the shoulder of the giant and become the next generation of neurosurgeons. Thank you very much for your time.
Thank you, Dr. Petra, for the wonderful lecture. So I would like to ask Dr. Liu to give expert comments.
Yeah, thanks. Thanks for your effort, Petra, to lure those young people to join neurosurgery. But again, as you mentioned, both ends, the reality as a neurosurgeon is still hard work, discipline. No, so I'm not sure how many percent are those young people, especially medical students, who know the reality. They may one day come and look for Petra. No, why you bring me in neurosurgery? You should have given me time to explore other discipline before come to neurosurgery. So, but it's still a good effort. But again, I think rather than we may mislead them, I think is to improve the work condition as a neurosurgeon. I think although is only limited to those people who are really strong, I think probably at this point in time. But this is not what we want. We want it can be handled by general doctors. And I think now we used to be a work only, no work-life balance. Probably we should now aim for life-work balance, not work-life balance. Life comes first, work comes second. If you can do that for neurosurgery, I believe that automatically student may come to you. So my question is, I would say that in a comprehensive, exposure for young doctors who are going to be a doctors among medical students, maybe I feel that exposing them to other medical specialty together with neurosurgery may be a good way for them to really evaluate what is they want, what actually things that they want. No, before you try to sell them one product that they may not like at the end of the day. Secondly, I think we also need to have ears and eye within medical school. I believe that there are some students who are from beginning you can see their talent. No, some people are extremely hardworking. No, sometimes they come at night rounds when they're not on duty among the medical students. I think those people should be targeted by you. So you must have a headhunter, within medical school to identify those good, so they don't go to cardiothoracic, for example, or being a cardiologist, wasted talent. What is your opinion regarding this, Petra?
Thank you so much, Dr. Liu. So I think you have the very core of my concerns, because these students, these talented students, most of the time they're being taken by internal medicine, actually, instead of other surgical specialties. Because when they are students and they haven't experienced the clinical rotations, it's all on paper, right? So it's all on paper, and internal medicine is very attractive to them because they learn and they can answer. They don't have too many situational things, what if, and not too many practical considerations. So our effort is also to steal these guys away from internal medicine. We need more people now who are researchers, actually, because our skills, they can be taught during the residency. Our lifestyle, well, they can see if it suits them or not, but they need to at least have the gray matter to become successful first in neurosurgery before continuing. So I really like your comments about the life-work balance. And I think it will be easier in the short future, because as more medical students come on to become neurosurgeons and they graduate, our workload will steadily decrease. Actually, that's the truth. Our workload will actually decrease in the future, and we'll have more life-work balance. And by making the social media, sometimes we have them in the middle of the night doing things, following our surgeries, our trauma surgeries as well. I think it will be a more honest outlook on what we do, instead of just if you leave it to the students, they'll have horror stories. For the student, I'm not allowed to sit for 18 hours, or I'm not allowed to come home for 2 days because of neurosurgery. But if we provide a more objective media, maybe they'll be more interested. Thank you for your questions.
Maybe one more last question to you, Petra. When I first joined neurosurgery in year 2001, one of my teacher told us that you can train a monkey to do a brain surgery, but you need to be someone to make the right decision in neurosurgery. What is your comment? Do you think is valid for today's? Thank you.
Oh, thank you, Dr. Lu. Yes, I think some part of that is still relevant because, well, like you said, if it's just the manual dexterity, you can train it, but you have to have the head and you have to have the heart for neurosurgery. I learned this very recently because some of my colleagues in the oncology center in my country, a lot of them become depressed because, neurosurgical patients in the oncology center, a lot of them doesn't have a good prognosis, right? So we have to train these kids. So if they have the heart, if they have the brains, and then maybe they can learn the skills and not the other way around. Just because somebody is interested in neurosurgery, in technical skills, that's the wrong way to look about it, I think.
Thank you very much. I like the whole compilation of your work. Hopefully, you can share the rights of the work compilation. Maybe we can adopt it as a part of the ACNS promotional kits. If allowed by Professor Kato, we may add on some other element from Italy or from other country to make it internationally. and we can use it to promote neurosurgery worldwide. Thank you, Petra, for your great work. Thank you.
Can I make a comment? Please.
Yeah, Dr. Uday.
Yeah, in India, like the situation is when we do our MBBS, most of the students are not at all exposed to neurosciences and neurosurgical work. In India, most of the hospitals now are doing neurosurgery. So we should start exposing the interns to neurosurgery, and then as we do our 3+3 course of a 3-year general surgery course, we should expose the general surgeons to neurosurgery and take the manpower and teach them also what neurosurgery is all about. So we cannot let loose the MBBS students, which they fear most, that neurosciences, the case facilitation, case examinations, trauma. So the intern should be kept with you. And in MS general surgery also, like you will be a general surgery training. The general surgeon should be exposed to neurosurgical procedures in OT at all time and in emergency and ICUs, so that they start building their foundations. They're not afraid of neurosurgery and they're not confused with it. Thank you.
Thank you.
Dr. Uday.
Yeah.
Yeah, so I think that's very important because a lot of neurosurgery for medical students is actually surrounded by fear and mystique, because they're like, oh, these guys will get mad at you if you miss the neurological finding, or these guys will be really angry if you don't know the name of the disease. I propose, let's just keep it down. For example, if they just get the disease process right, oh, this looks like a vascular thing, or this looks like a tumor thing, I'm happy with that. They don't have to give us a choice, meningioma or ependymoma. That's resident curriculum. That's what I find in these years. If we make it too complicated, if we expect too much from medical students, they're going to lose interest. So we have to put it back a bit. And later when they come to the neurosurgery program, and then we can go full throttle on them, I think. Thank you, Dr. Uday.
Yeah, Dr. Ben.
General surgery students should also be taken to the work because they have the core to build. They should not go into cardiothoracic and neurology where there is like a best of time.
Thank you, Dr. Ben. Yeah, please.
Yes, and thank you so much, Petra, and good presentation. First of all, I would congratulate on your work on the education to medical students or young neurosurgeons. And I was thinking that first I would echo with what Dr. Liu said. Maybe we could share this or organize some educational activity to those very young talent, maybe the medical student or very young trainee. And I think this is good that they know the foundation, the fundamental knowledge of the neurosurgery. I think this is something that we can consider to work on. And the second is how about the condition in your country? For example, is it difficult to get the neurosurgery post in your country? For example, if the competition is keen, for example, maybe each year that your hospital only have 1 to 2 vacancies for those residents. So it will make the situation different. Maybe the medical student will think that it's too difficult and the work is too tough, and they may not choose this specialty compared to other specialties. So what's your view and the situation in your country?
Thank you so much, Ben, for the question. So I was listening to the last part of the meeting from earlier, and sorry, Alberto, I missed the first part. But I really agree that we have to compile topics that's interesting, not only for young neurosurgeons, but maybe we should have a special segment for general population or for medical students. And I'm very happy, Ben, if you look at some materials from mine and we want to make some new ones, because they're in Indonesian, I'm sorry. I think we can make some in English, and as we suggested before, we'll have some content from Hong Kong or Italy and Japan as well, and make it a very good offering. So in my country right now, the acceptance rate for neurosurgery posts is maybe 1 in 5 applicants. And I think that's not bad, because 1 in 5 is okay. And most of the 1 in 5, they actually try again next year and they do get accepted. And I think that's pretty fair because even though there's a lot of interest, but we have to really select good ones because we can't just admit everybody. We have 4 residents per year right now. And I think we'll continue and see what's going on for the next couple of years. Thank you, Ben.
Thank you.
Something I would also like to add, we can give it a thought, that the internal medicine residents should also be kept in collaboration with the neurosurgical team. Why? Because they are the best people to judge stroke in emergency care within IHS score. And we just have 1 or 2 residents in neurosurgery and they cannot manage trauma, neuro ICU, and everything. So the internal medicine, they know how to manage the ICU in a kind of a way better. And they can team up with the other residents and surgical emergency can be managed better, especially the stroke from stroke point of view.
Taken. Thank you. Yeah.
If I may ask.
Yeah, Raj, please.
Yeah, hi. First of all, Petra, congratulations for this wonderful talk. I think Prof. Ika is in the attendees. I saw him. He's not accepting our invitation to be on the panelist. Nevertheless, it was wonderful talk and really congratulate you for putting this effort to woo the youngsters into neurosurgery. But I have an other side to tell you that the social media is like when kids get attracted to neurosurgery, like what you showed about the series where the heroes are neurosurgeons and all, and they have a like, I would like to become a neurosurgeon and all. But when they actually take up neurosurgery, they have such a rude shock of their life that they have no realistic they have no realization to what they have gotten into, and now it's too late to get out. I'm telling you this because we are a like high volume center. Kids come from all over the country to our place, and they have worked in smaller hospitals, one ICU with around 200, 300 beds. Suddenly they come here, they find around 20 ICUs, 4,000 beds, and there is no family, there is no sleep, around the clock operations, and nearly 1 or 2 end up taking psychiatric counseling and drugs. So this is happening every year. I have been seeing this since last 17 years. That's why I'm telling you. So social media is good, but I think before taking up neuro, should get at least 6 months rotation in any neurosurgery institute before taking this big step. That is what I would like to tell you.
Thank you, Raja. Yeah, Alberto, please.
Thank you. Thank you, Petra. And I think you and your team must be commended for your great job in this kind of educational activities and also promotional activities to attract medical doctors towards neurosurgery. I have just a couple of comments. So it's very interesting. First of all, it's very interesting to see how different these kind of issues are in different countries. In a country like Indonesia and in many other countries in the world, we lack neurosurgeons, and we need to find everything we can to attract young doctors to join neurosurgery. In other countries, like in my country, we have the opposite problem. We have too many neurosurgeons. Why I'm saying that? We all know this, but I'm saying that because I think in this phase, it's very important to attract young doctors towards neurosurgery, and it's necessary. It's also advisable to involve higher levels in the organization of this kind of planning, especially actually to plan the future. I believe that the situation we are in my country and also in other developed countries is the consequence of a bad planning of this kind of positions to be a specialist. This applies not only to neurosurgery, but also to other kind of subspecialties. If you don't have a good plan on a country, wise level, you might end up in having unbalanced situations with too many departments, neurosurgery, which implies too many neurosurgeons, which implies a lowering of cases per neurosurgeon, which implies unhappy neurosurgeons. At least a part of them might be unhappy. Why? Because they don't operate enough, because we are too many. So this is one comment. And the other comment is, I think that from one side, we need to be very clear with young generations about the fact that neurosurgery is not, with all the respect, dermatology or, internal medicine, in terms of efforts to be put on your job. For many reasons that we know. We have no time schedules. We have to, we also have to be stressed, not only psychologically, but also physically. And this must be put very clear at the beginning of the career, because otherwise the risk is the one Raja was saying, that they are shocked when they are entering neurosurgery, because they thought it was all cool and fascinating and easy and glamour. But in reality, neurosurgery is a very tough job. But on the other hand, I agree with you that nowadays we don't have the neurosurgeon like we used to have years ago. So the neurosurgeon who does everything, so who has a lot of stress in doing every kind of surgery. We have to deliver the message that neurosurgery can be many things. There are some neurosurgeons who are basically always on call, always ready to rush for emergency, but there are also some subspecialties within neurosurgery that don't require that. There are some subspecialty within neurosurgery which deal with elective cases only, basically, so you can better plan your life. And we need both kind of characters to be neurosurgeons. So this is an opportunity for young neurosurgeons. So be very clear about what a neurosurgeon can be in terms of stressful life and so on, but also give a positive message that, you can be a neurosurgeon without being so crazy and stressed and unbalanced in your life. Thank you anyway. It was a very inspiring presentation.
Thank you, Alberto. So we have one question from the audience that Petra, it's for you. Thank you so much for the presentation. What plans do you have for the nurses that work with you in terms of training in neurosurgery specialty?
Thank you so much for your question. So we are not yet like Japan, who have the specialty nurses for the neurosurgery, but we are trying to make it attractive to them as well. So we also have sent several to Fujita for further learning. And we also try to make a handbook, actually. We are trying to make several handbooks. So as Raj said earlier, so we need a handbook for medical students on their education level, for residents on their education level, and for nurses as well. So if they have something on their hand that they can refer to, I think it will take away a lot of the fear. It will take away a lot of the mystery and in neurosurgery, and they can start to enjoy. Because the internet is such a big place. If they just Google a procedure or Google a disease, they'll have so many wrong informations. So at least if we have several basic facts straight, it will be very good for the nurses. It will be very good for the students to be more interested in neurosurgery. Thank you so much.
Thank you, Petra. So there is one more hand from DKP. Yeah, you can ask.
Okay, good day. I'm greeting you from Nigeria. It's a privilege to be on this platform. This topic is important, more importantly from my own country side of view, where we have limited specialists in neurosurgery and also limited interest for medical students and graduates that want to pursue the career of neurosurgery. As a young resident, I'm in my second year in neurosurgery after finishing initial 4 years in general surgery. I think one of the problems we are having in this part of in my own country is the support system in terms of work-life balance. The career path is highly demanding, and if we can work around that so that people can have this sense of understanding that despite their choice of pursuing this demanding career, there is still chance that the work-life balance, time to take care of their family, immediate family and children will still be available to them. And also partnership with training institution and to ensure that the whole training is more formalized. Thank you.
Thank you. Yeah, Petra, do you want to say something?
Oh, yes, thank you. So I've never been to Nigeria, but I can very much resonate with your comment because there is always the challenge. Some people find it hard, some people find it difficult, but actually, I think for all of us in this room, I think we find it satisfying, even if it's hard, even if it's difficult, even if it sometimes takes too much from our life, of the time with our family, with our friends. I think we find it satisfying. And that's what keeps us being neurosurgeons. So that is also what I want to communicate to the next generation, because, you know, some people like to have the easy life. Some people like to be a family man. And of course, as Alberto said, maybe if we work in spine or we work in functional, maybe we do have the time. And we still can have the satisfaction of being neurosurgeon. So there's a lot of career paths, and I think if they know all about this before they start being neurosurgery, maybe they'll find a way that can be a good fit for their life. Thank you.
Thank you. Professor Ahmed Fahad, please. You can ask.
Okay. Assalamu alaikum and thank you very much. Arigato. I'm from Afghanistan. And thank you, Professor Petra, for your good proposal about writing textbooks. We are ready and we would like to appreciate your idea and also to have communication with you, with our other colleagues, especially for LMIC and countries like Afghanistan and other pure countries, but the common problems. And if you are agree, we make a curriculum for this side of globe and make write books, multi other textbooks, and we would be author also a chapter of this book as well. Thank you very much.
Thank you. Thank you, Professor. So it was a wonderful lecture. So are there any more questions or comments from the audience? So I would like to ask Professor Yuko Kato to give some comment about this wonderful presentation.
So thanks so much. So maybe I think already Dr. Olson, is she still with us now? But thank you so much.
Yeah.
The wonderful talk.
Thank you.
It's amazing topics. Thank you so much. I think in Japan, it's quite a limited place to do the thermal therapy for the tumors, like that. But I think we learned a lot from your lecture.
Thank you.
Sometimes is it a focus on the focus of the epilepsy after the treatment?
Do we get epilepsy after the treatment? No, it seems to be actually a good treatment for epilepsy, like epilepsy that caused by the radionecrosis or by the tumor. There's a good chance it will settle down after the laser. So, and of course, it's used for mesial temporal sclerosis or for corpus callosotomies. So, it's actually no, we haven't seen any epilepsy afterwards. No.
Okay, thanks. So please continue your research. The teachers again. Thank you so much. And Petra, thank you very much for your nice the guidance. Now is such kind of paradigm of the treatment of neurosurgical treatments. I think it's more getting less and less invasive for the patient. I think, and also some regulation of the working hour. So we must finish by 5 o'clock. So every time we have 3-4 the fellows from the world. So this time that everybody is joined webinar now, but there maybe I think disappointment because they want to have more see the direct surgery, but now we treat most of the stroke or cerebrovascular treatment is done by the radios, not the intervention and not endovascular treatment. I think. So in the future, I think maybe as most of the country the treatment by the radiologist, but I think you should take over from them. You can do it as a neurosurgeon to treat this kind of vascular lesion. And also the hands-on workshop include maybe I think radiosurgery or endovascular or endoscope. Maybe the focus should be a little bit changed, I think, in the future. So that is the more fluent for the next generation, I think. Thank you very much. It was a wonderful talk. Thanks.
Thank you, Sensei. I think it's good if minimal invasive and they can go home by 5. A lot of students will become to want neurosurgery.
So maybe I think Tanikawa Sensei is maximum invasive, I think. So now, now we have, of course, incorporate that we have a minimally invasive open surgery, not the Tanikawa fashion. I think you should learn a minimally invasive fashion. Thank you very much.
Thank you, Professor. Thank you. Yeah, so I will pass on to Dr. Alberto. Alberto, please.
Thank you, dear Issue. We had a wonderful webinar today, and I also want to thank both speakers. We can now move on to the very last part of our webinar. We have new fellows who joined recently Bantane Hospital, and I would like to kindly ask them to introduce themselves. I'm talking about Dr. Mohammad Aja, Dr. Abhishek Kumar, Dr. Gedefebi Pratama Kushma, and Dr. Otskan Songmets. They are coming from different countries, Jordan, India, Indonesia, and Turkey. So please, you can share your screen and give your short presentation.
Can you see my slides?
Yes, we can.
So, respected seniors, faculty members, colleagues of this esteemed prestigious fellowship from the Bantane Hospital. I am Dr. Abhishek Kumar. I am assistant professor in Department of Neurosurgery in Ram Manohar Hospital in Lucknow in India. And I have joined this fellowship last month. So I've completed 1 month of my fellowship here. So it is a lot of academic exposure, surgical excellence, and also a lot of cultural richness present in this place. And I am very honored that Professor Kato, she allowed me to do a fellowship here. So I am very indebted to her. She is a very good mentor and also a very good career advisor. So I did my MBBS and internship from Kastura Medical College, Manipal from 2008 to 14. And general surgery I did from Karnataka Institute of Medical Sciences, Hubli. I finished in 18. Then I did 2 years of neurosurgery senior residency program in Safdarjung Hospital, New Delhi. And then I did my neurosurgery MCH from 2020 to 23 from the SGPGI, Lucknow. My clinical areas of interest are hybrid cerebrovascular neurosurgery, which I'm learning here, endoscopic neurosurgery, skull-based tumors, and neuro-oncology. I also have a special interest in gliomas, operative and multimodality treatments. My vision and for future goals is to evolve into an innovative leader in neurosurgery and create structured mentorship pathways for new trainees. So as before me, the speakers were speaking a lot and I was listening, and it was very insightful that that's a high time that we create structured mentorship pathway programs for the new generation, and also build a global collaborations in neuro-oncology and vascular neurosurgery. So my goal is, after I go from here, I will apply all the techniques and whatever things I've learned to apply in my day-to-day practice and help my country. Thank you. Now I would like Dr. Muhammad Ajja to speak on about himself.
Hello, everybody. First of all, I want to thank Professor Yoko Kato for accepting my fellowship. She is such a mentor, and she is a wonderful person who helping the young neurosurgeon across the world. My name is Dr. Muhammad Ajja. I'm from Jordan. I finished my residency in 2022 for 6 years in the Ministry of Health of Jordan, rotating in multi-hospital for a national program of neurosurgery. I got my board of Jordan Medical Council in 2023, and now I'm a specialist in the Ministry of Health and a lecturer at Al-Balqa Applied University since 2024. I'm deeply interested in hybrid cerebrovascular, open and endovascular. Thank you, everyone.
Dr. Oskan.
Hello, everyone. Can you hear me?
Yes.
Yeah. Hello, everyone. Firstly, I would like to thank Dr. Yakakato for this opportunity. It's an honor to be part of this family. My name is Özcan Sönmez. I'm from Gaziantep, Turkey. I received my medical degree in 2017 from Istanbul University. After that, I completed my neurosurgery residency in Marmara University in Istanbul in 2023. After that, upon completed my residency, Health Ministry assigned me to Gaziantep City Hospital as part of my obligatory state service. It's my hospital bottom left. It's opened October 23. It's new hospital. It's a tertiary care, and it has almost 2,000 patient capacity. And our department has almost 48 patient inpatient service, and we have 15 ICU beds and 3 operation room, and we have almost 1,000 cases in a year. It's a huge caseload. In my current practice, I mostly deal with pediatric and cranial cases. You can see some cases that performed by me, and my interest in epilepsy surgery, low-grade gliomas, and vascular surgery. Thank you for everything.
Dr. Gede.
Yeah, thank you. Good evening, Professor and Doctor. My name is Gede Febi Pratama Kusuma. You can call me Kusuma. It is a great honor and pleasure for me to have this opportunity to undergo a fellowship in the Department of Neurosurgery at Bantane Hospital, Fujita Health University, under the esteemed mentorship of Professor Yoko Kato Sensei. So, my education history, I entered the neurosurgery residency program since 2022. Before joining the neurosurgery residency, I already become a lecturer in the Udayana University, Faculty of Medicine. And then, next slide. And then my research experiences. These are my latest researches that I did most of the research in traumatic brain injury. And next. So these are my list of publication. So next. And actually my main aim in this fellowship is I want to learn or experience new things in neurosurgery field that I don't have in my center, especially the neurofunctional surgeries, such as epilepsy surgery, movement disorders, stereotactic and peripheral nerve, and also the minimally invasive neurosurgery. And I hope I can make one manuscript with Professor Yoko Kato Sensei and affiliation for collaborative publication. And also I hope I can become the pioneer to build a collaborative relationship between our institution, which are Udayana University and Fujita Health University, Bantane Hospital, such as guest lecture exchange, fellowship exchange, webinar, live surgeries, and also journals, editorial board, and reviewer. Thank you.
Thank you, guys, for your self-presentation. I'm sure you will have a great scientific and also social time in Japan, and we wish you all the best. Of course, you are invited to join our alumni association at the end of your fellowship at Bantane Hospital. Now, before closing this webinar, I think Doctors Abida, Bunseng, and Ben would like to make some advertisement of some upcoming events and congresses. So maybe Abida.
Yeah, hi. So I want to invite everyone for the next ACNS, which is going to be held in Mumbai from 31st July to 3rd August. So exactly 1 year from now. So today should be the last day of the conference next year. And we will have a lot of opportunities for young neurosurgeons with reduced registrations, a lot of pre-conference workshops, live surgical workshops, and of course the main congress. And Mumbai is very good. It's the monsoon time here, and I'm sure you all will have a great educational extravaganza when you come here. So I take this opportunity to invite you all for this 15th ACNS next year in Mumbai.
Thank you, Abida. Bonseng, Liu.
Okay, I hope you can see my screen. This is on upcoming event of our late emeritus professor Teso Kano memorial lecture, which shall be held.
We can't see.
We can. Okay, now no. We
This
can
is some
see
farewell
Aaron party.
Oh, sorry, wrong one. Yeah, okay. May I present this first? Sorry. I just want to inform that from the Fujita Health University Bantane Hospital, we just had our farewell party with our one of the esteemed professor from Bantane. Last 2 days ago on Friday, I just some information. So it was held with staff of Bantane Neurosurgery, which are moderated by Professor Jun Tanabe, and also toast ceremony by Professor Haraguchi, and a message from others. So the Bantane have compiled a booklet where comprising all the publication of Professor Nakahara, and also messages from local and also international student, alumni student. And this is just a recap of his CV, where he graduated in 1953 from Tokyo Medical and Dental University. Also, he completed graduate school in medicine in Kyoto University, and received PhD from the same university. And in 1990, he also studied abroad in the Harvard University, Massachusetts General Hospital, and in neuroradiology. And he became an assistant professor in Department of Neurosurgery, Kyoto University in 1992. And subsequently, 5 years later, become a chief physician at the Department of Neurosurgery, National Cerebral and Cardiovascular Center. In April 2000, he was promoted to be a chief of the Department of Neurosurgery and director of Stroke Center of Kokura Memorial Hospital. And he was been appointed as a professor in neurosurgery at Fujita Health University in 2015. And also in 2016, he was the professor of stroke department of Fujita Health University and also deputy director of emergency and critical care center. And in April 2024, he then moved to Fujita Health University Bantane Hospital as a hospital special professor and deputy director of Cerebral Vascular Stroke Center. And in September 2025, he also, with the role of a special advisor to KG Cerebral Vascular Surgery, director of Cerebral Vascular Surgery in Fukuoka Shimizumaki Hospital, visiting professor at the Department of Neurosurgery, Fujita Health University of School of Medicine, specialist instructor of Japan Neurosurgical Society, specialist and instructor of the Japan Stroke Society, technical instructor of the Japan Society for Stroke Surgery, specialist and instructor of the Japan Society of Neuroendovascular Therapy, Japan Medical Association Certified Industrial Physician, Japan Brain Checkup Society Certified Physician, and also Japan Neurosurgical Dementia Society Certified Physician. This is a photo taken during the dinner. And so we have a toast for Professor Nakahara. And also, yes, also at the same time, we are also celebrating the professorship of Professor Jun Tanabe. So there's 2 cake there. And so these are the special cake for them and some gift for Professor Nakahara. And this during his speech during the farewell, and also passages from Professor Yokokato. And just a small video clip. So these are the attendees of the farewell party with Professor Nakahara. So thank you. And just to advertise, I would like to invite all to attend our, sorry, it's just too small, maybe, late Professor, Emeritus Professor Letes Okano Memorial Lecture, which will be held on 6th August on this Wednesday at 6 p.m. Japan time. We have 3 distinguished speakers. First was, I think, well known to all of us, Professor Wang Hee Dong from Vietnam, who will be talk about neuroendoscopy with limited resources, how we can do it. And also Professor mentioned from also a very famous Department of Neurosurgery in Hwasan Hospital, Fudan University, who will be speaking on the endoscopic extreme medical approach for the lateral skull base. And also another important and famous figures in minimal invasive neurosurgery from Indonesia, Professor Asra Al-Fauzi, who will speak on minimally invasive neurosurgery trend and future perspective. And we are honored to have Professor Andres Dimitris, who was the past president of ENS, to moderate this session. And we also have some distinguished discussion. I have shared, and I will share with rest of you regarding the link of this talk. That's all from me. Thank you.
Thank you, Dr. Liu. And finally, Dr. Ben.
Yes, hello, and shall I share my screen? I think Liu shared most of the ACNS activities, but I would also like to share this. So in Hong Kong, we organize this endoscopic transorbital workshop, and also with our annual science meeting, and we'll have a hands-on cadaveric dissection, and that you're also welcome to join us. In next year, we'll be organizing the ACN, the World YNS Congress, and in Hong Kong, but we haven't get the promotion site, the website, and also the program yet, and we'll work on this after this event. And then another things that I would suggest is that I recently went to a cadaveric dissection in China, and then with one of the ACNS member. And then this is some of the dissection work that we made. And in next year, and I'm negotiating them, maybe we could accommodate some of the young neurosurgeons that who are interested, that they're welcome to come with me for the in-depth, very excellent cadaveric dissection. And this is some of the cavernous sinus dissection that we do together. There's some of the bypass that we do on the cadaver. There's the temple bone, temple bone with the mastectomy. And then yes, and this is my sharing. So I hope we could get more activity for our young neurosurgeons in the future. Thank you so much.
Thank you, Ben, and thank you, Abida and Bonseng, for your talks about upcoming events. Very exciting chances, especially for young neurosurgeons, and for all of us together, finally, also physically and not only on webinars. So thank you very much. Professor Cato, do you want to say some final words before we close the webinar?
Yeah, thanks so much, because we missed one point learning today, because we invited Fukuda Sensei just 3 hours back, but he did not reply for us. So maybe next time, maybe we can find the 1 point learning talk, I think, yes, in the alumni webinar. Our 4 fellows, they went to the Nagoya City University for a cadaver dissection the last Saturday. They enjoyed the transpenoidal approach and transcribal approach. I think maybe the upcoming nights they are going to Osaka again with Dr. Avery from Peru. Again, the cadaver dissection course. So thank you very much. I think to do is very, very important for YNS. Thank you very much. Nice webinar.
Thank you, Professor Cato, and thanks to all of you who attended. Thank you to our speakers, and see you next month for the next Alumni Association webinar. Thank you, and have a good day or night.
Thank you, sir.